Well, thank you very much for that kind introduction. I hope everybody is staying warm, and I'm happy to discuss the neurologic complications of COVID-19. Today, we're going to talk about how this virus, the SARS-CoV-2 virus, enters the nervous system and how it affects cells in the nervous system. We're also going to describe some of the neurologic disorders that appear to occur secondary to COVID-19, including stroke and encephalitis. And then finally, we're going to discuss a little bit about how COVID-19 can affect the signs and symptoms of existing neurologic disorders. So first, we're going to talk about viral pathogenesis, or how the virus actually causes disease. So as many of you probably know, the SARS-CoV-2.
Dr. Racke?
Yes?
We can't see your screen.
You can't?
No.
Uh-oh. Well, let's see here. How do I escape that? Share screen. We will do this. Can you see it now? Okay,
No.
share, hold on.
There we go. Yeah, if you put it in
Now there.
Perfect.
How's that?
Thank you. Yes.
All right, sorry about that. All right, so we're going to talk a little bit about viral pathogenesis. That's how the virus actually causes disease in the nervous system. As many of you probably know, the SARS-CoV-2 virus was first noted in Wuhan, China in December of 2019. It's a single-stranded RNA virus. And from our perspective, the only reason that that's important to note is that when the virus gets into the cell, this RNA then instructs the machinery of the cell in the host, so the person that's infected, to actually make the virus. And it makes 4 proteins: the spike protein, the membrane protein, the envelope, and the nucleocapsid protein. It's the spike protein on the outside of the virus, you can see here, that gives it its appearance of a crown, and that's how it got the name coronavirus. Now, if you look at this picture, the other thing you can sort of see is that the spike protein is on the outside of the virus. And that's what the immune system sees. And so when you get infected with this virus, the immune system tries to recognize specifically that with both cellular means and with antibodies. And with the vaccine, what the vaccine does is it actually also uses RNA, just like the coronavirus does, to specifically make that S protein. And so your immune system, when you get vaccinated, recognizes the S protein and makes antibodies against it, so that if you get infected with the virus, it also makes antibodies against the virus. Now, the thing that's also important to recognize is that the vaccine only makes the S protein. It doesn't make any of the other proteins. It can't give you the disease. Whereas when you get infected with SARS-CoV-2, it makes all the proteins, and then actually your body assembles the virus, and that's how the virus then spreads throughout the body. Now, how does SARS-CoV-2 get into the body or into the nervous system? Well, it actually attaches to a specific receptor called the angiotensin converting enzyme receptor. Now, it's present in a lot of different organs, and not surprisingly, it's present in the lungs, and that's why you get the lung infection. It's also present in the bone marrow and spleen, and we're going to talk a little bit about some of the effects that it has there. It's also present in the kidneys and in the brain, and also the nasal and oral mucosa. And that's important because many of you probably have been tested for the virus. And one of the ways they test for it is by actually sticking that swab up into the nasal mucosa to try to get the material to test for the molecular presence of the virus. Now, in the brain, those ACE2 receptors is the other name that we use for that. is predominantly expressed in places like the thalamus, the cerebellum, and the inferior olivary nuclei. So this is the cerebellum, this is the thalamus, and these are where the inferior olivary nuclei are. Now, when you think about it coming in your nose, it comes in through what's called the olfactory epithelium, which is present where my arrow is showing here. That's one way it gets into the brain. If you're infected in your GI system, the nerves that are innervating the GI system can also allow the virus to come back here and then infect the brainstem. And that's another way that people think the virus can get into the brain. Now let's just talk about some of the clinical considerations of COVID-19. So coronaviruses are actually quite common. It's also what causes the common cold. And so, as I mentioned earlier, because the lungs have this as well as the nasal mucosa, that's an area where these viruses go. However, these viruses have been known for a long time to cause infections that affect the brain. And one of them is called murine hepatitis virus, which in mice causes hepatitis and also causes demyelination, which is what's seen in diseases like multiple sclerosis. It can also affect the GI tract, as I mentioned earlier. That's a mechanism of how we said it might get into the brain. And particularly in younger people like children and infants, it often causes gastroenteritis and diarrhea. I'm sure many of you have been screened about going in places worried about the virus, and obviously things that are very common are having a fever and a cough. But the thing that's another problem with this virus is that many people can be asymptomatic, and during that time they can shed a lot of virus, and that's how the virus can spread easily amongst people. Another common complaint is that people can have what's called myalgia. That means just that their muscles hurt, they're achy, and they're often tired or fatigued. Now, some of the things that we think about what the nervous system does, one of the really common things, and often the only manifestation that someone has COVID-19, is that they have anosmia, or they've lost their sense of smell. And as I mentioned earlier, the other places it can attack is in the oral mucosa where your taste buds are. And so in fact, you can lose taste. And it's also important to note that smell is a big part of how we taste. Now, I mentioned earlier about lymphopenia because it can get into the bone marrow and get into your spleen. And one of the things it can do is lower your white blood cell count. And so if that happens, it's actually affecting your body adversely in its ability to fight infection. And that can be associated with some of the people who end up having a higher mortality or die from the virus because they're not making a good immune response against the virus. Headache is something that also happens in patients, and we'll talk a little bit about some of those mechanisms later. The other thing that happens is that you will often hear about what people call, that the patients get what's called a cytokine storm. Now, those cytokines are proteins that actually signal amongst immune cells and also often are signaling from the immune system to the brain and within the brain. And so some of the treatments that we use actually try to target those specific cytokines to try to stop that cytokine storm. And the other thing that COVID-19, we're going to talk about, obviously, with this conference being focused on encephalitis, we're going to talk about that. But it can also affect the brain as a result of what happens if the virus is attacking, say, the lungs and the kidney. The respiratory and metabolic abnormalities that can happen will affect the brain because the brain wants to have high oxygen and wants all its metabolites to be normal. And if it's not normal, that can affect the brain, so the brain doesn't function properly, even though the virus isn't in the brain. Now, the other thing that happens is that COVID-19 has been shown to increase the ability for the blood to clot, something we refer to as hypercoagulability. I don't know, myself, I'm actually on blood thinner because I had a DVT once. And COVID-19 can cause you to have these increased clots. And if they have these increased clots, that can increase the risk of having a stroke because you can have clotting that blocks the arteries. It can block the veins that take the blood away from the brain. And when it happens in the brain, that's almost like having a stroke, like blocking the arteries, because the blood just can't move and oxygenate the brain properly. The other thing it can do is that the virus can attack the heart, and that can often lead to clots being formed within the heart that can flick off then and cause a stroke. It can also attack what we call the lining of the blood vessels and cause something we call vasculitis. And the vasculitis can cause inflammation that blocks the blood vessel, and that can also cause a stroke. So it's been very clear that COVID-19, particularly in people that otherwise don't have any risk factors for stroke, and young people in particular, have been seen to have strokes that we think are secondary to the virus. Now let's talk about some of the other neurologic complications of COVID-19. Now, before we talked about headache. Now, some of us get a headache. I don't know, like if you get the flu, you might get a headache. And I would say that's not because the virus has gone into the brain or the meninges. It's just a result of what I call a systemic illness. But you can also get meningitis, viral meningitis, or viral encephalitis. And that irritation of the coverings, when they're innervated, that actually sends a signal that says we feel like we have a headache, we have pain. And if we move our head or stretch our neck, we can have those symptoms of pain that are indicative of a viral meningitis. And one of the ways that we test for meningitis or encephalitis is that we look at the spinal fluid. And if you see increased cells, white blood cells in the spinal fluid, or increased protein, suggesting that the blood vessels may have been leaky, that may suggest that the patient's infected with COVID-19. Now, I just stuck these in here from the World Health Organization to point out that for disorders like meningitis, encephalitis, myelitis, or CNS vasculitis, one of the ways that obviously you can detect it is if in fact you detect the virus in the spinal fluid or in the brain tissue itself. But if you have an infection with, so if I did the nasal swab and I know that the person's infected with SARS-CoV-2 and they have symptoms of one of these viruses, or they have symptoms of neurological symptoms, like we talked about, like loss of smell, loss of taste, that obviously suggests that in addition to knowing that they have the virus, that they probably have neurologic involvement. Now, as I mentioned earlier, the virus can infect certain parts of the brain. Now, encephalitis, as I'm sure most of the people in this conference are familiar with, means inflammation in the brain. As I put down here, said earlier, encephalopathy doesn't necessarily mean inflammation in the brain. It means the brain is sick. And so, you know, the brain can be sick, as I mentioned earlier, because say my kidneys and my lungs aren't working properly, so my brain responds like it's sick because it's not getting the proper oxygen or it has the right metabolites. One of the ways we measure what's happening with the brain is we do what's called an EEG, or an electroencephalogram. That's where they hook the wires onto your head. And what we often see is that the electrical activity is very slow. And sometimes we see spikes that indicate that we may be at risk for having a seizure. As we mentioned earlier, we can look at the spinal fluid. And if we think there's encephalitis, then the white count is going to be up because there's actually active inflammation going on in the brain. An MRI of the brain is often done. Now, when you have encephalopathy, it's often normal, but if you have encephalitis, sometimes we see abnormalities that I'm going to show some pictures in a second. Now, one of the things that is interesting is this is now where we begin to see that people who have SARS-CoV-2 can begin to develop other types of encephalitis. So there have been patients that have had seizures, and they can have seizure activity like status epilepticus, which means seizure activity that doesn't stop. And often what we've found is that some patients actually have NMDA receptor encephalitis. They have the antibodies present in addition to having infection with the SARS-CoV-2 virus. So we suspect that what happens is the body, as it's responding to the virus, for whatever reason, is making antibodies that also react with the NMDA receptor. Now here we can see, this was a woman who had fever, cough, and was confused. And if you look here at the MRI and you see these arrows, you can see lesions in the brain. And here in particular, in both thalami that were infected, or places where the virus went in and began to cause damage in the brain. And so one of the things is that these types of complications are quite rare, but they do happen. Now, the other thing that can happen, as I mentioned earlier, is that when the body makes an immune response against the virus, sometimes this triggers other autoimmune phenomena that can affect both the central nervous system, which is the brain and the spinal cord, or the peripheral nervous system, which are basically the nerves that go to the rest of your body. And so what happens is you think that the virus has been cleared, and then several weeks later, the patients have another round of inflammation that affects the brain. And if it affects the brain, it's called acute disseminated encephalomyelitis. It can affect areas that are very important for memory, those areas in the temporal lobes, and we call that limbic encephalitis. It can also cause inflammation in the spinal cord, which we call transverse myelitis. Now, all of these have been reported in association with COVID-19 infection. They've all been quite rare. I should also note that in one of the vaccine trials, the AstraZeneca trial, not the Moderna or Pfizer trials, there was a case of transverse myelitis associated with one of those trials. And there are other types of rare types of, I guess we'd almost say, encephalitis. Obstaclonus, myoclonus is something that we typically see associated with cancer. This is where patients have their eyes moving around very quickly and muscle twitching. As I said, that's usually what we've referred to as a paraneoplastic syndrome, but it can also occur after a viral infection and has been reported in several cases after COVID-19. And so, as I mentioned earlier, that within 6 weeks, you can, after a COVID infection, you can have this acute disseminated myelitis. You can also have what we call Guillain-Barré syndrome, or acute inflammatory demyelinating polyradiculoneuropathy. You sometimes hear AIDP as well as Guillain-Barré syndrome. And what happens there is that the immune response has been triggered in such a way to make antibodies that actually target the peripheral nerves. Now, so those patients are going to have weakness. Now, as I mentioned earlier, you can have where the virus affects the GI tract. And so often the patients who, for whatever reason, get the Guillain-Barré have had a diarrheal illness. And there are different types of Guillain-Barré. The one that's most common is where people are weak and they've lost sensation. And their first complaint are going to be that their hands and feet are numb. And subsequently, they have this ascending paralysis, essentially. But you can get types like the Miller-Fisher variant that really affect more the cranial nerves, like my eye movements, but they also have what are called autonomic complications. Your autonomic nervous system, I always say to patients, that's your automatic nervous system. That's things like controlling your heart rate and blood pressure. And so if those nerves are affected, all of a sudden you're going to stand up and get lightheaded because your body doesn't accommodate properly to increase the blood pressure and heart rate, as well as respiratory symptoms. Now, a lumbar puncture in this instance typically is not going to show the SARS-CoV virus. Remember, the virus happened several weeks earlier. The immune system has been triggered. And with Guillain-Barré syndrome, typically you don't see an increase in immune cells, but you do see increased protein within the spinal fluid. Now we're going to talk a little bit about the effects of COVID-19 on existing neurologic disorders. So in general, if you have a neurologic disorder like Alzheimer's disease or multiple sclerosis or Parkinson's disease, those in and of itself don't predispose you to getting the virus. But similar to other types of infections, patients who have neurologic disorders, if they get COVID-19, the symptoms of that can be worse. And a lot of these neurologic disorders, particularly disorders like myasthenia gravis and multiple sclerosis, are treated with immunosuppressive agents. And so obviously that can affect the clinical expression of COVID-19, sometimes in a good way, sometimes in a bad way. And we'll talk about that a little bit more. So each of the specific neurologic societies, in some sense, have made some specific recommendations to patients with those disorders if they subsequently get COVID-19. Now, for multiple sclerosis, we've recommended that you don't change or stop your treatment unless you discuss it with the treating neurologist. One of the things that has been observed is that cytokine storm that we talked about earlier that sometimes can make COVID-19 much worse gets inhibited by the immunosuppressive treatments that you're on. And so for some of these patients, in fact, being on these treatments actually may be beneficial. Now, for a disorder like muscular dystrophy, where in general the patients feel weak, if the virus also affects the muscles, they could feel weaker. It's been very clear that patients with Parkinson's disease, while Parkinson's disease really doesn't have anything to do with the immune system and the way that you respond to the virus, just having that infection, just like if you would have the flu, can make the symptoms of Parkinson's disease worse. That's also true with Alzheimer's disease. Again, patients with Alzheimer's disease, if they get an infection, they often see worsening of their cognitive function. And that's also true with COVID-19. And then, as we mentioned before, if you have Guillain-Barré syndrome or CIDP, it doesn't change necessarily your ability to get COVID-19, but you may be on immunosuppressive agents treating that can increase the susceptibility to any infection. The American Academy of Neurology also put out some guidelines, and most of these are common sense, trying to say that if you weren't really sick, you could reschedule your appointment or go for a video visit, reschedule non-urgent visits and diagnostic testing. They want to reduce the number of people during essential in-person visits. And of course, on the physician side of things, make sure that you disinfect your tools and equipment and utilize appropriate PPE. Now, one of the things that I was involved with when I was president of the CMSC was the development of the Kovims Database. And at the end of January, over 1,840 MS patients with COVID-19 have been entered into the database. Now, interestingly, this is for people that have MS that had, for whatever reason, testing, or they were thought to have COVID-19 based on their symptoms. Now, similar to the general population, in terms of the percentage, 62 patients of these MS patients succumbed to COVID-19, and only 70 patients that had been submitted to the database had been asymptomatic. Now, obviously, there could be a lot more patients that actually had the virus, were asymptomatic, and for whatever reason, since they didn't know they had it, they weren't submitted to the database. But basically, it's very similar to what we've seen in the general population, that the vast majority of the patients who died had other underlying medical conditions. I'm sure many of you are aware that the patients who have things like type 2 diabetes and heart condition are overweight. Those are the patients that are most likely, and elderly patients, those are the patients who are most likely to die from COVID-19. And that was true also in the patients with multiple sclerosis. And of the patients who died, 60 of the patients were non-ambulatory, meaning they no longer were able to walk. And so those patients who are severely affected, and most of those patients who have progressive MS are also the older patients. Those were the patients that were most likely to have a poor outcome secondary to a COVID-19 infection. So I think in summary, we talked a little bit about the fact that the virus can affect the brain and the peripheral nerves, that the brain is, that you can have an encephalitis secondary to the virus. It can increase coagulability, and so increase the risk for things like stroke. And that subsequently, the immune response that happens to the virus can lead to things like NMDA receptor encephalitis, acute disseminated encephalomyelitis, and also things like Guillain-Barré syndrome. And that if you have underlying neurologic conditions, that those symptoms can sometimes worsen. So thank you very much for your attention. And at this point, I'm happy to take any questions that you might have.
Thank you so much, Dr. Racke. That was great. We do have several questions, but to keep us on track on time, I'm going to choose one of the ones that I think will be more applicable to this audience for people that have lingering symptoms or have had encephalitis. So if a person was really ill with COVID-19 symptoms before testing was available, and the opportunity for testing was outside the testable window, is it possible to have a lumbar puncture to find the antibodies no longer in the blood? And how would this knowledge help an encephalopathy patient navigate?
So that's actually a very good question. So typically, we've been looking for evidence of infection by looking at increased antibodies in the peripheral blood. And to be honest, I don't think we've actually done testing on spinal fluid in that manner. I would say that you certainly could look for the virus. And I think that's another very important question. To my knowledge, we have not seen that the virus itself is present for a long period of time in the spinal fluid. So for most people who have a normal, I would say even an abnormal immune response, the virus eventually does get cleared. And so for people who still have lingering symptoms, I think one of the things that's important to then evaluate is whether there's any other abnormalities, particularly I would say on imaging as well as spinal fluid, and whether it would require investigation for some of those autoimmune encephalitis like NMDA receptor encephalitis, which I have to, like I say, mention has been extremely rare, but I guess it's not rare for the person who got it.
Right, right. Thank you for that explanation. I'm actually going to ask you one more, if that's all right. Could you talk a little bit about the long-term neurological symptoms?
Okay, so I guess that, that is actually a very interesting question. So if you were to say to me, what has been the thing that most people are seeing, it's that they've had the viral infection and everybody has told them they've cleared the virus, they test them with the nasal swab and it's negative. And they say, I still just don't feel right. And so the question is that because of some underlying immune response that's going against some part of the brain or not? And I think that's, and the other thing that happens is I can tell you from my experience particularly in an MS, when we talk about the cytokine storm and those molecules are what the immune system signals with each other. When it gets into the brain, it sends signals to the brain. And I would say that cytokines that are overexpressed in the brain, that one of the manifestations of that is fatigue and feeling tired, And so I would say what happens is that even though the virus is cleared, the immune system takes a lot longer, particularly for whatever reason, in some people in the brain to shut down. And it's during that time when it hasn't shut down that often the patients complain of this in quote, brain fog or fatigue.
Okay, great. Well, again, we so appreciate you, Dr. Racke, and Quest Diagnostics for sponsoring the World Encephalitis Day conference. We appreciate your thoughtful presentation of how COVID is impacting people neurologically. I wish we could have asked all the questions that came in because there were a lot of good ones. We may have to send those to you and send the answers out to people later, but we look forward to the time when the majority of the population is vaccinated to prevent more deaths and hospitalizations, and especially no more neurological issues and long-term encephalitis related symptoms. So thank you once again.
Yeah, so if you have those questions, you could send them to me. I'd be happy to answer them, and you could get them back out to the people so that they can have those answers for them.
That's awesome. Thank you so much.
Great. Have a good day.
We will. Thank you.